Yeah, welcome to this session. I'll be taking you through active management of the third stage of labor. I am Dr. Adedeji Nife, a senior registrar in the Department of Obstetrics and Gynecology, Obafemi Awolowo University Teaching Hospitals Complex, Ile-Ife, Nigeria. At the end of this lecture, you should be able to define the third stage of labor. You should understand the method of management of third stage of labor. You should be able to define the management of third stage of labor. And you should know the components of active management after its definition. You should also be able to describe active management of third stage of labor if you are told to do so at any point in time. I'll be taking you through this outline. The third stage of labor has traditionally been defined as a period between the delivery of the baby and the delivery of the placenta and fetal membranes. The third stage of labor is the most perilous time for a woman who has just delivered because of the risk of postpartum hemorrhage. The third stage of labor usually lasts about 10 to 30 minutes, after which time it is said to be prolonged. There's an increased risk of postpartum hemorrhage, which is about 6 times higher for women who suffer from prolonged third stage of labor. The third stage of labor may be managed expectantly, that is the physiological management, or actively. In the expectant management of third stage of labor, or the physiological management, uterotonic drugs are not given. And then the cord may or may not be clamped early. The placenta also is delivered by maternal effort only. The physiological management involves waiting for the placenta separation and allowing the placenta to deliver either spontaneously or aided by minimal efforts. This is as defined by the World Health Organization. Active management of the third stage of labor involves interventions that are put in place to assist in expulsion of the placenta with the intention to reduce blood loss. These interventions are carried out in a sequential manner, which must be followed at all times. The interventions include administration of uterotonic drugs, clamping of the umbilical cord, and controlled traction of the umbilical cord. In the year 2007, the World Health Organization recommended supported active management of the third stage of labor as a critical intervention to prevent postpartum hemorrhage. While in the year 2012, there was modifications to the active management of labor by the World Health Organization. And in this latest review of active management of labor, the most active components of the active management of third stage of labor is the administration of uterotonic agents. The components of active management of labor are mainly 3. That is the interventions that need to be put in place to actively manage a woman in labor at the third stage. The first of these components is the administration of uterotonic drug within 1 minute of delivery of the baby after ruling out the presence of a second baby. The second component is clamping and cutting of the umbilical cord after pulsation of the cord assist, or within 1 to 3 minutes after the birth of the baby, or whichever comes first. Control cord traction during a contraction is the third component of the active management of third stage of labor. This helps to support the uterus while gently turning the placenta to deliver heat with the membrane to prevent the membrane from being retained in the genital tract. Now to administration of uterotonic drugs. Administering a uterotonic drug within 1 minute after the delivery of the baby promotes strong uterine contraction and leads to faster retraction of the uterus and placenta delivery. This helps to reduce the amount of maternal blood loss. It causes more effective uterine activity and also leads to reduction in the incidence of placenta retention. Based on results of multi-studies, the World Health Organization recommends oxytocin, that is 10 international units of oxytocin, to be given as the uterotonic drug in active management of third stage of labor. However, there are other alternatives in case where oxytocin is not available or where the birth attendant is not at liberty to administer oxytocin. Oxytocin, as we all know, has minimal side effects and can be used by all women. In the absence of oxytocin, as said earlier, other alternative drugs can be utilized in the active management of third stage of labor. And this alternative drug includes symptometrin. Symptometrin is a fixed drug combination of 0.5 mg of ergometrin and 5 international units of oxytocin, which is administered deep intramuscularly. Also, ergometrin can be used as an alternative. In this instance, 0.5 mg of ergometrin is given intramuscularly, and this should be given in patients without contraindications. The contraindications to ergometrin, which are known, include hypertensive disorders and patients with cardiac pathologies. Misoprostol also can be given. The advantage of misoprostol is that it can be administered orally, and it can be given by unskilled birth attendants. Misoprostol can be given at the dose of 600 or 400 microgram orally or sublingually, and this should be done in situations in which oxytocin is not available or the birth attendant is not at liberty to give oxytocin or injections. Recent evidences does not support the administration of misoprostol after oxytocin has been administered, and this should be noted by the birth attendants. Now to the clamping of the umbilical cord, which is the second component of the active management of third stage of labor. Clamping of the umbilical cord is recommended within 1 to 3 minutes of the delivery of the baby, especially when oxytocin has been given. There is no need to be in a hurry in clamping the umbilical cord. Even within a minute of delivery of the baby, clamping of the umbilical cord can be done. This is because the body naturally produces oxytocin, which also crosses through the placenta to the fetus, so it has no harm on the baby. Studies show that delaying the clamping of umbilical cord has additional benefits in both term and preterm fetuses. In full-term babies, fewer cases of anemia were recorded, and increased duration of early breastfeeding was also noted when the cord was clamped within 1 to 3 minutes, that is, in delayed cord clamping. Delayed clamping of the cord may be helpful. In situations where cord clamping and cutting was delayed for preterm babies, these infants were found to have higher hematocrits and reduced rates and need for blood transfusion. However, for the mother of the baby, there was no significant difference in blood loss when patients who had early cord clamping were compared to those with delayed cord clamping. The third component of the active management of labor in the traditional package, which was early cord clamping, that segment was removed and replaced with early cord clamping because it seems to have no maternal effects. There are, however, reasons where one may need to clamp the cord very early. In cases of preterm or growth-restricted fetuses due to risk of hypervolemia, in babies that need active resuscitation, the cord may be clamped very early. Also in resource isoimmunization to prevent flow of fetal to maternal blood, early cord clamping may be adopted. Also in patients who are HIV positive to prevent maternal to fetal transmission of HIV infection, early cord clamping may be advocated. Then in mothers with diabetes, the cord is expected to be clamped early. However, after clamping the cord, there are signs of placental separation that one may need to watch for, especially as traction is being applied on the placenta to deliver it from the birth canal. The uterus becomes globular, firm, and ballotable. Also, the fundal height increases slightly as the placenta separates and descends into the lower uterine segment. One may also notice slight bulge in the suprapubic area, which is a pointer to separated placenta, or a gush of blood from the birth canal, which also indicates separation of the placenta. Controlled cord traction This is another component of the active management of third stage of labor. It helps with a rapid delivery of the placenta. It is important that the placenta be quickly removed from the birth canal after it has been delivered. This is to prevent the placenta from being entrapped within the birth cavity and subsequently leading to postpartum hemorrhage. The umbilical cord, as said earlier, should be clamped close to the maternal perineum and held with a hand, gently held with a hand, while the second hand is placed slightly above the suprapubic area and displays cephalad. This applies counter traction on the uterus, while the dominant hand pulls on the placenta to deliver the placenta from the birth canal. In cases where the placenta does not deliver over a period of 30 to 40 seconds, one has to wait for another uterine contraction to come in place, which usually takes about 2 to 3 minutes before further traction is applied. The non-dominant hand, which is placed above the suprapubic region, helps to prevent uterine inversion from taking place, and this is important as it is known to be a cause of massive postpartum hemorrhage and maternal shock. This is a pictorial representation of controlled cord traction. This is the non-dominant hand placed slightly above the suprapubic region to prevent a uterine inversion, while the dominant hand holds the umbilical cord and delivers the cord and the placenta from the birth canal. And this is showing the aperture taken at the delivery of the placenta. Controlled cord traction may be delayed until the next contraction if with one contraction the placenta is not delivered. The World Health Organization, the International Federation of Obstetrics and Gynecology, and the International Confederation of Midwives recommended that in the absence of a skilled birth provider or skilled birth attendant, the third stage of labor should be managed by administration of uterotonic drug without controlled cord traction. So, if you are not a skilled birth attendant, you are not expected to perform controlled cord traction, as this may lead to maternal mortality and severe morbidity. The active management of third stage of labor was reviewed by the World Health Organization in the year 2012. And these are the outcome of the review that was done. Immediate cord clamping does not increase the risk of postpartum hemorrhage, and it is the least important of the three components of active management of third stage of labor. Delaying the clamping of cord for about 1 to 3 minutes reduces the risk of fetal anemia and reduces the need for fetal blood transfusion. Hence, delayed cord clamping should be encouraged. The administration of uterotonic drugs, that is oxytocin, remains the most important part or the most important component of active management of third stage of labor. The performance of controlled cord traction and immediate massage of the uterus for some every 15 minutes for over 2 hours after delivery of the baby are optional components in the active management of third stage of labor. The World Health Organization also demonstrated that controlled cord traction did nothing with respect to reduction in postpartum hemorrhage, and women who received controlled cord traction had only 10 mils of blood loss less than those who did not receive controlled cord traction. So this minimal blood loss is negligible. But where the real difference exists in terms of active management of third stage of labor and the expectant management is in the duration of management of third stage of labor. The interval of management of third stage of labor is about 6 minutes shorter when the active management of third stage of labor is employed as against the expectant management of third stage of labor. And this is with respect to those who had controlled cord traction. The use of uterotonic drugs to prevent postpartum hemorrhage during the third stage of labor is recommended for all births, irrespective of where these births are taking place. For births that are taken in the hospital or at home, uterotonic drug comes first as a component of the active management of third stage of labor. And the recommended drug for management of third stage of labor is 10 international units of oxytocin, which is administered intramuscularly. Postpartum vigilance is important in patients who have just delivered. This ensures that the uterus is well contracted and prevents uterine atony, which is a common cause of massive postpartum hemorrhage. And in this, the uterus should be examined every 15 minutes for the first 2 hours following the delivery of the fetus. Uterine massage can be done by the patients or the mother or her relatives in cases where it is not convenient for the parturient. Oxytocin quality and supply should be ensured. As it is known, oxytocin has to be kept in the refrigerator between 2 to 8 degrees Celsius. So this cold chain must be employed and must be consistent. And this is the only way oxytocin will be effective in active management of third stage of labor. As said earlier, in settings where skilled birth attendants are not available, controlled contraction is not recommended by the World Health Organization. Sustained massage of the uterus is not recommended where prophylactic oxytocin, that is the 10 international units, has been given. So there is no need to massage the uterus except the patient has high risk for postpartum hemorrhage. Controlled contraction is the recommended method for the removal of the placenta, even at cesarean section. The active management of third stage of labor reduces the incidence of postpartum hemorrhage. It reduces the need for blood transfusion. It minimizes the use of therapeutic uterotonic drugs during the third stage of labor or within the first 24 hours following the delivery. However, women considered low risk of postpartum hemorrhage had a reduction in blood loss and need for transfusion, but no incidence in the risk of severe postpartum hemorrhage when active management of third stage of labor is employed. Active management of third stage of labor is not without complication. The most common complication is postpartum hemorrhage, which is known to be a cause of maternal mortality and severe morbidity. Other complications which may attend active management of third stage of labor include genital tract laceration, retained placenta where controlled contraction is not applied on time, or in situations where ergometrin is used in the management of third stage of labor. Acute uterine inversion is another complication that may be seen in patients who have had active management of third stage of labor, and this is the reason why controlled contraction is not to be done by unskilled birth attendants. In summary, the active management of third stage of labor consists of sequential interventions that are put in place to deliver the placenta and to limit the blood loss in third stage of labor. Modifications to active management of third stage of labor has occurred over time. Hence, knowledge of management must be up to date. The active management of third stage of labor can be practiced by all birth attendants. However, those who are unskilled are not supposed to administer intramuscular injections and are not expected to carry out controlled contraction. Active management of third stage of labor involves administration of oxytocin, cord clamping, in this case delayed cord clamping within the first to third minutes of delivery of the baby, and controlled contraction by skilled birth attendants. This intervention has been found to reduce the risk of postpartum hemorrhage, reduce retained placenta, the need for therapeutic oxytocin, and the need for fetal and maternal transfusion. These are my references. You can go through the references to learn more about active management of third stage of labor. Thank you so much for listening.